Good. So here we go. We got a young guy. He's 18 years old. He has an instability event. I manage it non-operatively. He has another subluxation event. I said, listen, you're going to probably need to have surgery. And as is typical in my geography, you know, unlike Canada, they go for a second opinion. So Parsons sees this guy, and as it turns out, he says, well, I can fix you. And Sethi says he can do it in 4 weeks. Well, I'll do it lickety-split. And Parsons steals the case. The patient called me and said, listen, Dr. Parsons told me that he sees you at conferences all the time. And I'm like, oh, he said, Dr. Parsons, he's always instructing the conferences that he sees you at. I said, oh. Well, anyway, I called Raffy. Raff, do you see your face in the bottom here? That's what your face looked like when Brad stole the case from me. So just one more time.
Angry.
Pop star, not a doctor. Anyway, patient calls me and says, listen, Dr. Parsons told me it was a really, really bad tear, but he was able to repair the tear, and quite fortunate that he does so many of these. And I'm trying to tell the mom, as it turns out, my patients call me Dr. McDreamy, and now you can too.
You asked me to be on this panel just to bust my chops?
Actually, that was the whole job. I'm out. I'm pretty much done right now. All right, so moving on. Brock, are you here?
I'm here.
Brock, how did Brad do? Here's his images. Here's his anterior images.
Best as I can tell with just 2 pictures, it looks like he did a typical Parsons bang-up job. Lickety split.
Lickety split.
Thanks, Brock.
Brad, you touched on it, but I want to have Brock wearing the Duke jacket in this picture, interestingly. Brock, do you use a posterior inferior anchor? How often? Any other technical issues you want to emphasize on this?
Yeah, no, I think it's actually, and Brad talked about this in his actual talk. I think I've seen that help quite a bit. You know, gives you almost kind of a little bit of a kind of a reverse remplissage, or, you know, kind of a glenoid based tether in the back. It addresses that inferior component. So very commonly I do in this case. And what you're showing there is kind of the typical technique where you grab a tuck of capsule and labrum and incorporate the two.
Nick, do they lose range of motion when you add a posterior inferior suture?
No, I don't think so. You know, I think all of these patients lose a touch of external rotation. I don't see a significant internal rotation deficit. And I think more often than not, particularly if they have recurrence, you'll find that that Bankart goes back beyond 6 o'clock if you start elevating it up. And so more often than not, I'm putting an anchor back there.
Joe, is there anyone in whom a posterior inferior anchor is contraindicated?
I don't do it that often, to be honest. I don't think it's
time. Joe,
I don't do a posterior inferior anchor that often. So for me, I don't tend to do this anchor. I know it's a lot, it's talked about a lot, but I haven't seen a problem not doing it. Is there anyone contraindicated? If it's not torn, why fix it? But I don't necessarily think there's a contraindication. I think when you're talking about these percutaneous anchors, I think it came up during Brad's talk when he said, you have to sort of push the envelope. I think you have to know kind of what you're doing and dilate these percutaneously carefully. I mean, there is a lot of badness there. It's not just going through the subscap, etc. You know, you got to be careful about these anchor placements.
All right. Well, you know,
Probably the throwing athlete is the one you got to be careful with, because if they lose motion, it's the kiss of death for them. If it's their throwing shoulder and a throwing athlete.
Whiteside Stocker, got it. So on the panel, I've got everyone but Joe doing a posterior inferior. Serena, Guido, Butch, yay or nay?
No, I actually don't do a posterior inferior anchor, and I think that Joe is actually he said something very sophisticated in his usual kind of Philly way, very quietly. But the purpose of the posterior inferior anchor is to give you something to tighten the fasciculus obliquus between the anterior and posterior inferior bands. And if that goes around 6 o'clock, as Nick was saying, but you're actually shifting the entire capsule and labrum, doing a capsule labral shift around that, you can probably achieve the same thing just as you're trying to mimic an open shift without a posterior inferior anchor. So I don't routinely do it either.
Guido, Serena.
I didn't know I said that, Butch, but it sounds really good. Thank you.
Brad, can you say fasciculus obliquus?
Not even close. I can say acronym.
It's not an acronym.
He's looking up how to spell it.